This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2016, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Today's topic is Impact of Comorbid Conditions on Obstructive Sleep Apnea. Dr. Karen Schell is a registered respiratory therapist, neonatal pediatric specialist, registered pulmonary function technologist, and clinical assistant professor at the University of Kansas Medical Center in Kansas City. Dr. Schell has no conflict of interest related to this presentation. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis.
Hello, my name is Karen Schell. I'm a clinical associate professor at the Respiratory Care program at Kansas City, Kansas in the KU Medical Center program. I'm here today to talk to you a little bit about comorbidities and obstructive sleep apnea. Today we're going to cover several things, and under that we're going to look at the prevalence of obstructive sleep apnea and the incidence of it with some comorbidities. And the diseases we're going to focus on are type 2 diabetes, cardiovascular disease, and hypertension and stroke. We're also going to look at some risk factors associated with those comorbidities, how to diagnose them, and treatment and the benefit of that therapy. If we look at the background of sleep apnea, we know that it's estimated about 70 million people nationwide have some sort of sleep disorders. It's a common sleep disorders include the narcolepsy, insomnia, and sleep apnea. And it's estimated about 18 million people suffer from obstructive sleep apnea. The prevalence includes about 10% of the adult population, and when we look at that population, we also understand that the prevalence also includes over 50% in the elderly. It's really highly prevalent in adults. We know that 1 in 5 adults have at least mild OSA, and if we look at 1 in 15 adults have OSA of moderate or more severity. Also, if we look at 75 to 80% of OSA cases could benefit from the treatment, remain undiagnosed. So there's a large group of patients out there that haven't even the realization that they have the disease. And just breaking it down a bit more, the male to female ratio is 8:1. And when we look at women, women are less likely to be evaluated and diagnosed. Also, when we look at OSA, sleep deprivation and undiagnosed sleep disorders make up about America's most severe health problem. Poor sleep associated with this development and poor control of obesity and diabetes happens. About 38,000 people die from cardiovascular disease with complications from untreated OSA every year. And if we look at the age group as we grow older, as our population is getting older, OSA increases with the age 2 to 3-fold higher as they go over the age of 65 years. Some data suggests that OSA in older age is distinct from that of the middle-aged adult. So this data hasn't been addressed enough, so it's kind of sparse data, but could be future studies that we're looking at the difference between the age of middle age to older age. We need a better understanding of the older age and how it differs from the middle age because, again, as our population is getting older, this will be a significant health problem in the future that we need to be addressing now so that we can take care of those patients in the future. About over 80% of the people suffering from sleep disorder breathing are undiagnosed. And that's, again, a very significant number. If we look out into the population and 80% don't even know they have the problem, again, we're going to be affecting a lot of our comorbidities, other diseases, as we'll discuss later in the slides. Sleep disorder breathing really disrupts breathing patterns and causes a lot of the following. It decreases the oxygen level in the body, swings blood pressure, so we have hemodynamic issues because we have varying of blood pressures out throughout the night. It increases our sympathetic nervous system activity, and it shunts oxygenated blood into the major organs, so our major organs don't get enough blood. There's higher incidence in patients with a stroke compared to those patients that have non-stroke. So again, we're looking at how this OSA undiagnosed can affect the rest of the diseases that are out there. If we just go back and simply define sleep disordered breathing, we know that sleep disordered breathing describes a number of different breathing disorders, and those include obstructive sleep apnea. Again, obstructive sleep apnea is when there's a physical blockage of the airway so that the airway doesn't stay open and you don't get enough oxygen into your blood. We also look at central sleep apnea, and central sleep apnea is when the brain tells you to quit breathing. So those are part of it. And we also, associated with that, are nocturnal hypoventilation, which the patient simply doesn't breathe deep enough to oxygenate, and chain stroke respirations. When we take a look at the prevalence of sleep apnea in comorbidities, this slide demonstrates quite a few things that can be affected by obstructive sleep apnea. We look at the highest ranking here at drug-resistant hypertension. When we look at hypertension and how it affects the body system and the blood getting to the rest of the body, this is a significant number of patients that sleep apnea can affect. Also listed here is obesity, congestive heart failure, type 2 diabetes, patients with pacemaker, patients that have atrial fibrillation, and all patients with hypertension, and then those that have coronary artery disease. When we look at diabetes itself, and this is a problem not only in the US but worldwide, diabetes is increasing, and right now they estimate about 250 million people with diabetes throughout the world, and they expect it to be over 380 million by 2025. So 7 out of 10 countries with the highest number of people living in them with diabetes are in the developing world. Again, so we can have a great impact on the progression of this disease if we're diagnosing it early enough, and if OSA is intertwined with that, how we can affect the health of the world. Over 100 million people worldwide are affected by sleep apnea, and when we look at that number, 80% of those are undiagnosed. So there's a big significance on how we can help the health of the world if we're looking at this disease. The prevalence rate is higher in the obese population, so we know that obesity plays a role in it. When we look at type 2 diabetes, first look at obstructive sleep apnea and how it is associated with it. Obstructive sleep apnea can cause insulin resistance, glucose intolerance, type 2 diabetes, and metabolic syndrome, independent of obesity. So up to 83% of people with type 2 diabetes suffer from an unrecognized OSA, or obstructive sleep apnea. And we see an increasing severity of OSA is associated with the worsening glucose control. So we have a vicious cycle going on with our patients. Their diabetes can be worse, and their sleep apnea can affect that. So if we can treat not only their diabetes, but their sleep apnea, we can help improve the health of the patient. When we talk about insulin dependency, we're looking at elevated sympathetic nervous activity with the untreated sleep disorders of breathing. And that sleep disruption occurs, and then we get a chronic sleep debt. And when that occurs, hypoxia impairs, because we're having hypoxia from the obstructive sleep apnea, that impairs the glucose metabolism. And so early metabolic syndrome occurs with the sleep disorder breathing before the clinical manifestations of the disease. So again, early screening is important, and we must look at our patients that have diabetes and make sure that we're looking at factors that could affect their sleep. And I think if you flip that over, those with obstructive sleep apnea, we need to be looking at factors that affect diabetes. So those two kind of interact with each other. It's kind of a circular thing, reaction. If you have one, you might have the other. So we should be screening for both when we have those kind of patients come into the office. With type 2 diabetes, sleep apnea, when it's untreated, can really lead to poor overall treatment outcomes. But however, despite the number of type 2 diabetes patients with sleep disordered breathing, it largely goes undiagnosed. Again, if we had screening tools in place for every patient that was diagnosed with diabetes, then we can catch their OSA, and hopefully we can be able to get the patient treated appropriately to control their diabetes better. And according to the International Diabetes Federation, they recognize that between type 2 diabetes and sleep apnea, and they recommend that routine screening for OSA patients and for type 2 diabetes. So both are recommended. If you have one, you should be screened for the other. Also, the evidence supports that there is an independent association between OSA and insulin resistance and the glucose intolerance. But this link kind of, we don't exactly know how it happens, so this link is undetermined, so there's more research needed to investigate that. And really the role of OSA in the management of type 2 diabetes is really in need of being investigated so that we can find the factors that cause that. We really have a question that remains whether OSA represents the independent rise for development of diabetes or pre-diabetes. So there's research that needs to be out there. And we know too, along with obesity and how obesity affects the sleep apnea, that it also affects diabetes. So notably, if we can get the glucose and the diabetes under control, we can control the weight, and weight loss has also been effective in helping those patients with OSA and also with their diabetes. So it's kind of interlocked with each other. There's still some debate whether a patient that is treated with CPAP for their sleep apnea, whether that improves the glucose metabolism, and also how long or how much CPAP is effective to improve that metabolic outcome is still under research, and it still remains to be determined. So I think once now that everybody recognizes the link, there's more research being developed, so we should be able to at some point figure out how we can work this together. But again, we go back, it's important to screen, make sure that you're asking the right questions when those patients come in. And we want to try to identify any phenotypes of OSA patients who show better metabolic responses to CPAP, and then we will be able to better treat those patients if we can do that type. So again, that research is scarce, and we're waiting for that to come to have more relevance so that we can start using better treatment for our diabetic patients. We also need to look at other diseases when we talk about our patients, and one of the ones that we want to talk about today is cardiovascular disease. Looking at diseases that are kind of all connected anyway, when we look at cardiovascular disease and OSA links, we're really looking at hypertension, and we're looking at both systemic and pulmonary. We're looking at heart failure, systolic and diastolic. We're also looking at rhythm disturbances. We're looking at ST segment changes, atrial fib. Again, we go back to metabolic syndrome, left ventricular systolic function, myocardial infarction, diabetes, stroke, and TIAs. All of these cardiovascular diseases are linked to OSA, and if we can pinpoint the treatment, we'll have better results for our patients. This next slide just briefly goes over the prevalence of sleep apnea in cardiovascular disease patients. Our OSA patients' prevalence is high in patients with hypertension. And when we talk about hypertension, we also talk about recurrent hypertension, or drug-resistant hypertension, along with just hypertension. And you can see that the drug-resistant hypertension on this graph shows that we see a prevalence of a lot of patients that have this drug-resistant hypertension with OSA. So again, we look back at treatment, the OSA could help with that drug-resistant hypertension. And on a personal note, I've seen it happen in the sleep lab where we've had patients come in on numerous hypertensive drugs, and they're unable to control their blood pressure, but as soon as we diagnose them with a sleep test and put them on CPAP, they've come off of those drugs. So we know there's a correlation. If we look at the longitudinal population study, persons with a moderate or worse OSA are 3 times at odds of developing hypertension. So again, we go back to that circular motion. If you have OSA, you are more likely to develop hypertension. If you have hypertension, you're more likely to have OSA. And it can be drug-resistant hypertension. Then when we compare it to persons that don't have OSA. So there is a correlation there. If we also look at patients then with CHF, we know that, again, OSA affects the estimated 15 million adult Americans. If it is present in a large proportion of patients with hypertension and other cardiovascular disease. And so we need to go and look how it affects our patients with CHF. And with CHF, we see central sleep apnea occurring in those patients. And patients with CHF, their OSA range from 11 to 37%. So patients suffering from CHF is not well controlled tend to have 11 to 37% are with obstructive sleep apnea. If we treat that OSA with the CHF patient for a month, one study associated that increase, that showed an increase in their ejection fraction. So we know and a decrease in their diastolic blood pressure. So even 1 month of treatment of a patient with CHF can improve the health of our patients by increasing their ejection fraction and decreasing their diastolic blood pressure and heart rate. So routine screening, I'm going to go back, this is a theme throughout. Routine screening is important with all of these diseases in order for us to treat the patient appropriately and get their either CHF, their diabetes, or their OSA under control. When we look at the mechanisms for disease associated with cardiovascular risk, I talked a bit about how we have severe desaturations and a waxing, waning of our blood pressure. But we also see that severe intermittent hypoxemia and the CO2 retention during sleep. This disrupts the normal sleep pattern, and this can cause autonomic and hemodynamic responses to sleep. And what happens, in a nutshell, is that it's accompanied by a chemoreflex mediated, that increases the sympathetic activity to peripheral blood vessels, and that causes vasoconstriction. And when you have vasoconstriction, your blood pressure rises, and that can cause hemodynamic stress, which then initiates the pathophysiological mechanism that acts to promote the cardio and vascular disease. So going back again to our previous slides about blood pressure, when we look at this, then we know that hypoxemia and CO2 retention affects the blood flow, and our pressures go up, and then it affects our hemodynamics to the heart, and the heart has to work harder, the blood pressure goes up, and the patient has to adjust that. So it promotes that cardiac and vascular disease. This next slide is kind of a busy slide, but it's, I think, important to understand, if you look at it, how OSA induces all these things we've previously talked about. So OSA may induce this severe intermittent hypoxemia, and that when I talk about severe, I'm talking about less or equal to 60% saturation. CO2 is retained, and that disrupts the normal autonomic and hemodynamic response to the sleep. The patient wakes up. The apneas occur repeatedly through the night, and they're accompanied by the chemoreflex mediator, and that causes the sympathetic reflexes activity to the blood vessels, causing that constriction again. So if you look at the slide, you can see the progression as the patient goes through the night and how it associates. So we get increased blood pressure, we get a hemodynamic stress occurs at the time of that hypoxemia, and we get hypercapnia, and we get adrenergic activation, which then promotes the cardiac and vascular disease. So it's, again, a stair-step effect that we look at. So if we can treat the cause from the beginning with the OSA, then we can prevent some of the other disease from happening. And most of our patients don't realize that they have a sleep problem until they have another comorbidity show up. So they're not screened appropriately to begin with. Some of our patients already come in with high blood pressure, congestive heart failure, they're diabetic, but all along they've had sleep apnea over the years, and this has caused their disease to increase, and that's why they are having problems with it. So if we can treat the underlying cause, then we can prevent it. So again, I'm going back to the screening. It's very important to screen even before the onset of the disease. If we could catch it early and treat the OSA, then we wouldn't progress into the rest of those diseases. And I think the public is not aware of that, and a lot of times I think the physicians need to be reminded to do some screening. And I think as respiratory therapists, we have an important role in that we can help identify our patients when they come to the hospital if they're having sleep apnea, to help the patient realize that they need to come in and be further tested. Just a little bit, these are kind of complex theories, what we think about, but what happens with pathophysiological mechanisms, I talked about that the sympathetic activation occurs. We get a faster heart rate. We get pressure during their blood pressure increases during their wakefulness and resting. We also see cardiovascular variability. That means this is really a precursor to high blood pressure or hypertension and eventually in organ damage. We see vasoactive substances, that recurrent hypoxemia. Stress really induces increased release of those vasoactive or tropic substances that cause the vasoconstriction to occur, and that can last over hours. So if you're repeatedly doing that during the night, these things are going on in the rest of your body. That triggers an inflammation. That hypoxemia appears to be the mechanism to trigger the inflammation, and that sleep deprivation may also have a role in that because you're constantly waking up to breathe, and so this triggers this inflammation, and once that occurs, then we keep going down the rabbit hole because we don't have time to treat the underlying cause. We're treating the result of the underlying cause. So again, if we can catch that early, we can prevent hypertension to occur. Other things that happen is we have an oxidative stress. This repetitive hypoxemia and reoxygenation throughout the night may be implicated in triggering this oxidative stress mechanism, which in turn affects the endothelial dysfunction and causes the inflammation and causes that pressure surge to occur, and the oxidative stress may all contribute to that development. And then here comes insulin resistance because the increased catecholamines, sleep deprivation, and the other pathophysiological characteristic of OSA may be associated with that insulin. So again, when I spoke earlier about more research is needed to see how that mechanism works so that we can stop this cycle of downhill going. We also note that there's thrombosis that occurs with OSA because of increased platelet activation and increased potential markers of thrombotic risk. So it's important, again, to be aware of those things with your sleep patients because these things could be happening and you don't know about them. When I talked about interthoracic pressure changes, what we're doing is when you breathe in and out, you have this increased repetitive force during inspiration against a closed upper airway, and this generates a negative pressure in the chest, which increases the transmural gradient across the heart, the atria, and the ventricle, so the heart has to work harder to pump blood throughout the system, and this can disrupt ventricular function and cause hemodynamic instability. This really causes an increased stress to the walls of the heart, and that can lead to the congestive heart failure because our pumping mechanism isn't working as well. We can have an increased afterload and an increased atrial size because the heart has to work harder and the wall strength has lost its ability, and it also is impaired diastolic function and thoracic dilation and can lead towards a dissection. So again, we go back to the blood pressure and how it is affected by the sleep apnea, and the changes in pressure can affect the internal organs and the heart particularly. What we're looking for then is the prevalence of arrhythmias in sleep apnea. Just a little bit more about that. Reportedly, that more frequent in persons with OSA, and we see an increased number of episodes and associated with the hypoxemia when we see atrial fib. And we know that nocturnal arrhythmias have been shown to occur up to 50% more with patients with OSA. Just think about it. They're not getting enough oxygen to their heart, and their heart's going to have to work harder. They're going to have to figure out a way to get that blood around, so they have different arrhythmias. We know that we see a lot of arrhythmias during sleep, and if you work in a sleep lab, they can be kind of frightening at times because we'll see some non-sustained VTAC, and we always, as a respiratory therapist, think we need to treat that right away. We see sinus arrest. We can see second-degree AV conduction. So those things are all affected by the obstructive sleep apnea. And with those patients in atrial, when we're talking about that, tracheostomy can help suppress those arrhythmias, but of course we don't want to have our patients be treated that has arrhythmia with a trach every time. We know the mechanisms for atrial fib include hypoxemia, and I talked about sympathetic activation, the pressure surges from high to low blood pressures throughout the apnea episodes and reoxygenation episodes, the transmural pressure changes, and the systemic inflammation. We know that OSA leads to atrial fib. It's really appealing because it makes sense, but again, there's not enough research to support that. So that's another thing that they're looking at to see. It's really an unproven hypothesis at this time, but it certainly would make sense to think so. On our ventricular arrhythmias, then, we're looking at premature ventricular contractions that have been reported up to in 60% of patients with sleep apnea. There's really no conclusive data demonstrating that this is a primary etiologic role for OSA in the ventricular arrhythmias, but again, it makes sense. When we look at the treatment of sleep apnea with arrhythmias, again, we're not seeing any interventions that would relate it specifically to the treatment. If we look at sleep apnea effects on arrhythmias, we really don't have any conclusive evidence or interventions that specifically relate to the prevalence and severity of that consequence of that cardioarrhythmia. So again, something that needs to be studied a little bit more. Bradyarrhythmias, we know that apnea events may be primary cause of the absence of that coexisting pathology, but bradyarrhythmias also are reported in REM in sleep healthy adults. So again, there's an association if it's caused by the OSA or is that just a natural occurrence? Because when we get into deep sleep, we do have a lower heart rate normally. If we look at the treatment of arrhythmias and the effects on sleep apnea, a report of atrial overdrive pacing in patients with pacemaker implantations for bradyarrhythmias did help with 50% reduction in the obstructive sleep apneas. So this has really generated interest in the research arena to help maybe look at the pacing of the heart and see if it can help with the treatment of OSA. So we have OSA looking at how to treat the arrhythmias, but we also have treating the arrhythmias to help treat the OSA. Another one that we look at is heart failure. The Sleep Heart study found presence of OSA had a fourfold increase in the diagnosis of heart failure. And then the OSA, as I talked about before, is associated with the lower ejection fraction, and the patients with the left ventricular systolic dysfunction have a high prevalence of OSA. Again, we go back to, is the chicken before the egg or the egg before the chicken? When we look at OSA, is it the heart or is it the OSA causing the heart to have problems? And further study is being done on that as well. Heart failure and complex sleep apnea is a form of sleep apnea that occurs which has central apneas that are persistent or emerge as you treat the obstructive sleep apnea with CPAP or a bilevel device. So again, when we're looking at those patients, they're more complex in treatment because as we add CPAP at higher pressures, we can cause some central apneas, which again would cause some hypoxemia and go through our cycle again. So we have to have a really good education and skill on how to apply our pressures because we can end up causing more harm than we do good. And so there's adaptive pressure support or servo ventilation to help with that. It really provides variable amounts of ventilator support during that breathing and during that chain stroke breathing that could occur with central sleep apneas. And these monitor the minute ventilation and the volume and adjust the pressure support to achieve that target ventilation. So those patients are more complex to treat because we're actually inducing more apnea than we're treating, and we need to be able to have a device that works well for them. And these patients are difficult to treat in that, as I said before, you typically start off with a CPAP. You don't know how the CPAP's going to react with them, and you have to go into the servo adaptation to actually treat it. As we look at pulmonary hypertension, OSA is a secondary cause of pulmonary artery hypertension. Remember we talked about the pressure gradient changes and the changes in blood pressure. It only makes sense that our pulmonary artery would be affected by this as well. And when it has to pump blood, it actually is high and it can't get to the pulmonary system to be oxygenated. Usually mild, but it becomes more severe with exercise. And we have a post-capillary nature of the pulmonary artery hypertension, and is secondary to that left ventricular diastolic dysfunction. We talked about the heart having that effect, how it loses its wall strength and can't pump as well. So our left ventricular doesn't work as well, and it can cause the pressures to the pulmonary artery to do that. Studies show that the capillary fill of the pulmonary artery. Hypertension may be from hypoxemia itself. So again, with the desaturation during the night, with the person airway blocking off and oxygen level going down, this can, over a period of time, cause pulmonary artery hypertension. When we look at coronary artery disease, I talked about earlier going back and making sure we're screening patients. And if a patient is diagnosed with coronary artery disease, we need to look at see if they have, there could be suspicion of OSA because they're having nocturnal cardiac events. Then we want to go back and screen and make sure that they aren't having OSA. In those patients, we might see silent ST changes or nocturnal angina, arrhythmias, myocardial infarctions. And these are the patients we see that come into the hospital that have not been tested particularly for OSA, and they're being treated for these different arrhythmias, and their treatment isn't working. So that if we can screen them and take them into the sleep lab, we may be able to find out what's causing that. Nocturnal ischemia, common during REM sleep with patients with cardiac artery disease and with OSA. So we see that again happening during night, during sleep. When we look at myocardial ischemia and infarction, we look at the prevalence of sleep disordered breathing in the coronary artery diseases. Patients have been shown to be a twofold greater, again, than the non-coronary artery disease subjects. Potential triggers for this ischemia, again, goes back to the hypoxemia, the acidosis caused by the increased level of CO2 in the blood, increased blood pressure, and the sympathetic cardiac transmural pressures. Sleep apnea has been implicated in these patients with nighttime angina. And so again, going back to our screening tool and looking at the whole picture of the patient and not just focusing on the heart is important to do. If we look at the effects of myocardial ischemia and infarction, the treatment of OSA can suggest that the patients with combined OSA and coronary artery disease has associated with a decrease in occurrence in the new cardiovascular events. So if we can treat those patients that have cardiac events or arrhythmias or ischemia or infarction, then we have decreased the risk of those happening again. Again, many of our sleep patients that come into the sleep lab show that they've had a cardiac incident before. So if we could have got them earlier on in the process, we could have prevented it. Up to 40% of our patients that have heart disease or had an event with their heart have sleep apnea, so we know it's highly correlated. If we treat this sleep apnea, then we can get from our patients anecdotally that they describe that they have marked changes in their sleep patterns, that their snoring decreases, they've witnessed apneas that occur after bypass, and then sometimes they even have angioplasties that, again, we're looking at those patients that have those things done and they come home post-surgery, that more studies are needed to see how if it's affected. So CPAP is a treatment that can help those patients. When we look at the OSA and the prevalence in hypertension, 50% of OSA patients are hypertensive, and that's very significant in itself. It's estimated that about 30% of hypertensive patients also have OSA, and those are often undiagnosed. Again, we go back to the screening. If we can look at our screening tools and look at our patients when they come in and we're taking care of them, and not just look at what they're coming in for. They're coming in for high blood pressure, coming in maybe for diabetes. We start to look at the whole picture and include the obstructive sleep apnea screening tool in with that. We might be able to have less severity of the disease and be able to treat the patient better. If we look at sleep disorder breathing and hypertension, we know that sleep disorder breathing have an increased risk of developing hypertension, independent of all of the relevant risk of factors. So it is a risk that is related to the sleep disorder breathing severity. The more severe the sleep disorder breathing, the greater the risk of developing that hypertension. So we're going back to our circle again. We're going back to disease process that affects another disease that we need to be treating. And if we don't treat one of them, and if we don't treat all of them, we're going to still go back into that circle. So we need to keep doing diligent work and involving all of the disease processes and looking at everything and not just one portion of it. During healthy sleep, blood pressure decreases, but during sleep disorder breathing, patients instead have tend to experience elevated blood pressure during sleep and a prolonged cardiovascular stress, which can then lead to that increased blood pressure also occurring during the day. So our patients may just be experiencing high blood pressure at night during their sleep episodes and hasn't affected their daytime blood pressure, but as this progresses, it can start to affect their daytime blood pressure as well. And typically, physicians and practitioners look at the high blood pressure during the day. They start to treat with medications, and then we see the resistant blood pressure treatment that doesn't work for the patient. So then, what are we going to do because drugs aren't working? And instead, we should be looking at the causes as well as the treatment. And I think sleep awareness now has come more. Physicians and practitioners are more aware of it and incorporating that into their physical assessment, but we still have a lot of education out there to do, not only to our patients, but to our practitioners, because I think sometimes we're so focused on the problem, we don't look at how the problem occurred. So with that, sleep disorders, breathing, and hypertension, those with the 30% we talked about patients with hypertension, and now we know that about 80% of those patients have drug-resistant hypertension. For this group of patients in particular, the treatment of positive pressure may be especially important so that we can get their blood pressure down because the drug isn't working. The effects of hypertension with the treatment of OSA, if we look at the other side of it, treatment of OSA by the CPAP has been shown to be markedly decrease the blood pressure during sleep. So again, another good thing. Additionally, the short-term CPAP treatment in patients with well-controlled hypertension doesn't always elicit a blood pressure improvement. So again, we're going to have to look at our patient and fine-tune our treatment so that we're either treating a combined with blood pressure and medications, or we decide the circle so the circle won't continue. Studies have also shown that more patients with severe OSA have difficult to control hypertension, and better CPAP compliance may be the issue. Okay, we know what it is, we know they have problems, but are they wearing their mask? Are they using their machine appropriately? So a lot of times we can find a treatment that's effective, but our patient isn't compliant. So we have to do a lot of patient education. Also note that the hypertensive patients who cannot tolerate the CPAP can use some other devices besides CPAP, such as oral appliances, and they can also work effectively to decrease blood pressure. So if one piece of equipment doesn't work, there's alternatives to help that patient achieve the level that they need to treat that. If we get treatment of the hypertension affects the OSA, really there's no current evidence that any specific antihypertensive drug has a direct effect on our OSA, the sleep severity. But conversely, a recent report suggests that a cough and rhinopharyngeal inflammation induced by an angiotensin-converting enzyme inhibitor may worsen the apnea-hypopnea index. So again, we're treating a patient with medication, it may actually cause more problems for their OSA. So that's something to be aware of as our patients are being treated. And we may need to discontinue that drug and try an alternative. Just a little bit about stroke now. Because OSA occurs in stroke patients, what happens with a vascular injury, the respiratory and the other centers of respiration for central sleep apnea and OSA happen after a post-stroke. And there's studies out not knowing if the OSA or the sleep apnea caused the stroke or the stroke caused the OSA. So we can't assume either or. So we need to make sure that we're treating the patient effectively to maintain their airway so that we can get them through the post-stroke stage. And these characteristics your breathing characteristics can change per individually after a stroke because of where the stroke occurred. So we, again, need to monitor those patients. Those majority of patients who have experienced a stroke or a TIA have a sleep disordered breathing problem, which sometimes is undiagnosed before they have it, but also it occurs after the stroke, so it occurs then. So a stroke potentially can cause a sleep disordered breathing problem, but we really don't know the mechanisms of that as well. So we just need to do the treatment on it. When we look at OSA and the origin or the progression of the stroke, concept of sleep apnea is at risk for a primary stroke is mostly inferential and really derives from evidence implicating sleep apnea and hypotensive and heart disease. So again, our risk factors that we talked about, that if you're not getting enough oxygen because you're not having a good heartbeat to get the blood to the brain, you could cause a stroke, or again, we're not sure that that has a mechanism, but it's implicated. Blood pressure swings, we talked about the high blood pressure to low blood pressure. Again, are we getting enough blood to the brain to cause some problems with cerebral blood flow that would actually cause the stroke to occur? It's just, and we talked also about thrombosis, so we could have a blood clot occur from that as well. So again, we look back at that. People with sleep disordered breathing may be more predisposed to stroke through a number of symptoms they experience. They can have that repetitive drop in nocturnal blood oxygen, and then that can cause that hypoxia, and that can be showed to be part of the, as we talked about before, the systematic inflammation. So what impact does the sleep disordered breathing have on stroke then? With patients that have both sleep disordered breathing and stroke, they usually show poor compliance. If you can imagine trying to get a patient to wear a mask post-stroke in a rehab program, it's really due to the combination of defects of the stroke and the symptoms of the stroke, such as daytime sleepiness, fatigue, and impaired cognitive functioning. How do you recognize and diagnose sleep disorder breathing in stroke patients or stroke survivors? Again, when we look at a stroke survivor, it's really very challenging because we don't know if it's an effect of sleep apnea, or it's often attributed to the stroke itself. So a complete history is necessary to make sure that our patients so you can determine whether that sleep disorder breathing or the stroke is really impairing their breathing after stroke. There is some effects that immediately after acute stroke, central sleep apneas may occur, but as they start to improve, they actually have more obstructive sleep apnea. So this prevalence is, of sleep apnea can occur for several months until they start to recover from the stroke. In those patients with the treatment of OSA in stroke patients, that non-invasive positive airway pressure ventilation is sometimes more effective than CPAP because you're augmenting their ventilation. CPAP compliance is sometimes not good, again, because those patients are recovering from the stroke and it really hasn't benefited them, and it's difficult for them to adjust to it. Whether the patients with stroke or OSA benefit from the treatment with CPAP really does remain to be determined. And again, more studies are being done to determine that. So just a few things to go over before we finish. Treatment options in OSA. We talked about today a little bit about weight loss, how it can lead to improve your sleep apnea by decreasing your apnea-hypopnea index. It improves your sleep efficiency because you're not waking up during the night because you're not breathing, and it decreases snoring and improves your oxygenation. Weight loss is good for diabetes. Weight loss is good for cardiac heart disease. Weight loss is good for obesity. So we look again at the overall picture of the patient. It can only benefit the patient. CPAP applied via the nasal mask continues to be the primary treatment for OSA, and adherence tends to be a primary problem for the patient. Is getting the patient to wear the treatment that benefits them. So education is very important to find out any problems or understanding of the importance of wearing it, plus troubleshooting the patient's devices to see that they're appropriate for them. When the CPAP proves to be unacceptable, then there's the oral appliances they can use and be considered. And really, surgery is designed to be the last step for it. So we can go to tracheostomy to help with the airway obstruction, but again, this is not a fun thing to go through, and surgery for tracheostomy is not really elective. You don't want to do that if you can be treated another way. And certainly, it would be not considered in those cases that a CPAP is effective for because it's costly. And insurances are going to go for the device that works appropriately and least invasively. So when we go back and look at our patient, it really comes back to education. And when we look at the circle of those caregivers involved, it's not just one caregiver that's doing the education or the screening or the diagnosis. It takes a team to really do that. And when we talk about team dynamics, we're talking about a continuum of care. It just doesn't stop at the sleep lab. It doesn't stop at the doctor's office with the diagnosis. It doesn't stop with the patient when they go home. This is a continuous process that has to be reevaluated because medications change, treatment change, and all of this is very important for the patient to understand so that they lose weight. If they lose weight, the CPAP level may be too high and we need to decrease it. So that continuum of care is very important. We also talked about early diagnosis and detection, and I think again that comes back to screening tools for all disease processes that includes a sleep screening tool to be able to make sure that our patients are being treated appropriately for the underlying cause and not just treating the actual disease process. And then the follow-up care is probably, again, very important because our lifestyle changes. As we get older, things change in our life and the medications that are out there that are available change. So continue follow-up and make sure the effective treatment is being effective for the patients. If you have any questions, I've left you with my email and the references are listed on the back. I'd be glad to answer any of those. Feel free to contact me, and in the future, good luck.